Welcome to Call the Doctor, and it is a real pleasure to welcome back.
Thank you for having me back.
Thank you, Dr. Kemper, Bernard Kemper, and I hope that you didn't miss the last time I was on about 3 weeks ago, because I mean I have had more fun telling people about the anterior hip replacement with minimal. I do what you did and say the incisions are this long.
That was big Longhorn side.
And nobody can believe that.
I mean, that's what we're doing. It's doing great. The funny part is, after we did this a couple weeks ago, I had patients in my own clinic that said, I was just afraid to call in and tell you how it went. And it's like, don't be afraid. Just give us a call if you hear us talking. Even if you just want to say hi.
Yeah, and Sandra answers the calls, and then she sticks her head in and tells us what you asked. So, you know, we'd love to have you call. And I have to say, with the 4 calls that we had last time you were on, we've never had that many before.
Yeah,
so people,
they were great questions.
And you know what that says to me, though? People are hurting at home and they're scared to move forward. And that's so much the reason that this show is important, because you're putting them at ease by telling them that, you know, people have great quality of life coming out of what happens when they have good surgery when they need it. So
absolutely. And I think today we're talking about the knee. All right. So I was asked earlier about, let's talk about the knee, and one of the things that I frequently get asked in my clinic is, what is a meniscus tear? What is a cartilage tear? Well, I got a little model here, and it's going to be difficult to see, but the cartilage in the knee, there's different types. The best way that I can explain it to people is, do you ever eat chicken wings?
Yeah.
So
Love
the
chicken wings.
end of the chicken wing, between the 2 bones, there's the slippery, smooth cartilage, right? And then there's what people call the gristle. Nobody likes to eat the gristle, right? It's rough, and it's rubbery. And that's what your meniscus is.
Oh.
Your meniscus
It's the gristle.
Is the gristle.
Okay.
It's the rubbery part of the knee. And this will be difficult to see. I don't know if we get someone to zoom in. Here's my fake knee.
Yeah, Johnny, see if you can.
Lee, I tried to get a bigger one from my office. I could not.
Zoom in.
And what you can see is, if you look here, you can see this knee has arthritis already. But
wait, how do you know it has arthritis?
Because the blue slippery cartilage is gone.
Oh, okay.
But if we look underneath, what you can see in this white bumper, which is hard to see, that's the meniscus. And the meniscus is like a little donut of tough, rubbery cartilage. And that donut does a couple of things. One, it acts as a shock absorber, right? So if you're out running, it helps your knee absorb the wear and the tear whenever you're running along. The other thing it does is it actually helps the knee bend and flex, and it helps guide the knee through a range of motion. So the meniscus is a very important part of cartilage, even though it's not the smooth, slippery part of cartilage that people typically think of with arthritis. Now there's 2 different types of meniscus tears that I would like to talk about. You can then divide those into a lot of different other subtypes that my sports surgeons love to talk about. For me, there's 2 types. One is the meniscus tear in the young athlete, right? Out playing tennis, out playing basketball, go up, jump, come down, twist your knee, tore your meniscus. Your knee is otherwise completely fine. No degenerative tears, nothing else is going on the knee. Those patients can actually get meniscus repairs if you're young enough, and the meniscus can heal back.
How do you repair it? Sew it?
You sew it, yep. There's different types of devices you can use to sew inside of the knee, usually through little camera holes. It does depend on where the tear is at inside the knee. Sometimes you'd have to create another incision to essentially tie the thread. But they're making pretty good advancements in that minimally invasive surgery as well.
Do they glue it at all? Can you glue?
Unfortunately, we don't have a good surgical glue for that yet.
Okay.
We're trying.
Yet.
We're trying.
But the stitches, then, they stay there for forever until...
Yep, they're forever. And what they do is they essentially act like a cast or a splint for the meniscus to try to heal back to itself.
Okay. Do they dissolve once it heals back? Or?
No, they just kind of stay in there forever.
Okay.
But they don't hurt anything, so they just kind of hang out. Now, the other type of tear is whenever you kind of have arthritis coming in, right? So you've lost the smooth, slippery, shock-absorbing cartilage other than the meniscus already. The way I explain this to people, it's like if you're chewing gum, and all of a sudden you bite your cheek. Your cheek is the meniscus. It wasn't that your cheek was there. It's not that your cheek is the problem. It's that the teeth, the now exposed bone, pinched and tore the meniscus. And everybody knows how bad that hurts when you bite your cheek, right?
Yeah, and then it sticks out and you keep biting it.
Correct, and the exact same thing happens in your knee if you tear your meniscus. So that is the arthritic or the degenerative meniscus tear. There's 2 different options for that. One, sometimes you just have to go and take the little meniscus tear out. Little minimally invasive surgery, home the same day, pretty low risk. The biggest risk with that is you have the arthritis coming in underneath. So sometimes you don't treat the meniscus tear, even though it's there. You actually have to treat the arthritis, otherwise it'll bite the other meniscus or tear something else.
How do you treat the arthritis?
Well, there's different ways to treat arthritis. We all try to start treating arthritis with non-operative treatments. We were talking earlier about things to try to do to prevent arthritis. Some of the best things you can do to prevent arthritis is stay moving. Staying active, don't let the knee get stiff, stay light, and stay physically fit.
By light, you mean not overweight.
Not overweight, correct.
What happens with, how does weight affect your knees?
So weight doesn't cause arthritis, a common misconception. What weight can do, though, is it can accelerate arthritis. Arthritis is a genetic predisposition, so if you have arthritis, you probably got it from your mom or your father, usually your mother. And then, if you add weight into the equation, every 1 pound on the scale is 3 pounds to the middle side of your knee, and it's 10 pounds underneath your kneecap. And the most important when it adds that weight is in uncomfortable activities already, like going up and down steps.
Oh, okay.
Yeah.
What do you consider a good exercise to keep doing throughout your life
Yeah.
to prevent it?
There are great exercises for knee health. Those are things that you kind of take away the gravity so you don't pressure the cartilage. But the cartilage actually does get a little bit of nutrients whenever you make it move. So things such as
interesting.
like low resistant spiking, water aerobics, those are probably the two best things that you can do for keep your joints healthy. Also just low light aerobic impact that you then add in weight or gravity, such as like light jogging on soft ground, all that stuff does seem to actually prolong the life of cartilage.
Let's talk about soft ground since you mentioned that. I've heard of runners eventually having problems because does the running cause the problem?
The running doesn't cause the problem. Any sports injury whenever you're younger can cause a problem, an ACL tear being probably one of the biggest ones. But I tell most people who are active with knee arthritis, I say, listen, those patients typically have worse knee arthritis on x-ray. They're less symptomatic earlier on, and their x-rays have to advance to so much more cartilage loss before they can actually feel the arthritis kick in. That's because their muscles are strong, their knees still limber because they keep it moving. They just get symptomatic or they feel pain not nearly as early as the people who are not as active.
Give you an interesting example of that very thing. My son was walking in a crosswalk in Seattle to his job, and somebody was apparently blinded by the sun and hit him hard. He had just run in the Big Sur Marathon, so he was in excellent shape.
Yeah.
He couldn't stand up, and I mean it just really hurt him badly, but he ended up with a great recovery, and the doctor said it was because he was in such good shape.
Yep, the last thing that I want any of my patients to ever do is stop moving. Please keep moving. If you're getting to the point where the activities you enjoy to do, or you're not doing more because your knee or your hip hurts so much, please come see us. Like that's when we should get involved early. We can help with physical therapy, right? That helps get those small muscles around the knee, make the knee track better. Same thing with the hip. Medications that are, non-inflammatory medications, so your starter versions of ibuprofen. We try to stay away from narcotic pain medicine because it actually makes arthritis pain worse in a year.
Oh, huh.
Yeah, we don't quite understand that one in the medical world yet, but we do see a trend that the opioid narcotic pain medicine makes it worse, which is unfortunate because a lot of people need strong medicine to get their pain under control. After that, there's always the injections. Everyone loves their cortisone injections.
But does that over time do some damage to the...
Yeah, so that's a great question. We studied it in lab, and what we know is when people get cortisone shots, the cartilage does seem to degrade quicker than those who do not.
So it's the cartilage, not the bone, that degrades.
It's the cartilage, not the bone, that degrades. But my question for that is the studies were not like done on people who just signed up willy-nilly, right?
Yeah.
They were done on people who had arthritis. So what came first, the degradation of the cartilage, and then you got the steroid shot, but the cartilage was already degrading. Did it accelerate it, or was it just the process already going?
And it's hard to measure that, isn't it?
That's impossible to measure unless you really do a really well-controlled study.
Well, you showed me the arthritis in that knee. Is there such a thing as surgery to just cut out arthritis?
So one of the things that we used to do in the past was go through and trim up the bone spurs. You probably heard that pretty
Yeah.
often. Is I went and had my bone spurs all nice and trimmed up and my knee cleaned out. A knee clean out job right now would be like the meniscus tear, the degenerative or the arthritic meniscus tear. However, we don't usually recommend removing the bone spurs anymore.
Why? They hurt.
They do hurt, but the bone spur exists because of the arthritis. The bone spur exists because the knee has lost the cartilage. When the knee starts losing the cartilage, the weight that that piece of bone sees goes up by 10 times minimum. So the bone tries to make itself harder and then bigger by creating these bone spurs.
So it's trying to help itself.
It's trying to help itself. I always tell my patients the knee is stupid, and then it backfires, and then it hurts more. So we don't recommend removing the bone spurs anymore. And additionally, if you're young, like your son, one of the reasons he had the great recovery is because his cartilage was still good. And your cartilage is still waterproof when it's pristine. Once the cartilage gets damaged and degrades, it's no longer waterproof.
Okay.
So we stick in all the instruments and whatnot to try to clean stuff up for an arthritic knee, and it actually makes people hurt worse. So we don't recommend a full cleanup job on knees anymore, unfortunately.
What would, if you're talking to young people or parents, what would you say to them if they want to really bulletproof as far as needing this for their kids to the best thing? To stay active? I mean, is that just clearly, does what's your nutrition or any of that come into play?
Sure, so nutrition's hard to study because it's so various, right? I mean, all ethnicities have different types of food. We do know that carbohydrates tend to increase inflammatory markers.
Oh.
And people who have bad arthritis will tell you if they have a high carbohydrate meal, like go out and have a bunch of pasta and like wine, unfortunately, that they can actually get more swelling inside of their knee.
My husband was having lunch with some people, and they were saying that they went off white rice, white bread, white cake or sugar, and felt a whole lot better. Their arthritis got a lot better.
Yeah, most people recommend the Mediterranean diet, which is just lower in processed foods, lower in processed carbohydrates, and that really seems to lower inflammation levels. So I do recommend high protein diets to my patients for many things: weight loss, decrease inflammation.
Ketosis? Is that or ketone?
You don't
the
really
keto
have to
diet?
go full keto, but just try to limit the amount of processed carbs that you're doing. So try to limit the amount of Oreos.
I know we had one. Sandra, do we have a call? Okay. See, you're off to a good
There we
start.
go.
Let's see if I can get this one right. He had vascular surgery on the leg
Okay.
3 years ago. He said he desperately needs a knee replacement, and he was told that might not be a good idea by a orthopedic.
Sure.
You want to
So-
repeat the question, though.
So the phone call that we had was somebody had a previous vascular surgery done on the knee or on the leg to help out with a previous condition, and they're wondering if a knee replacement can be an option for them. That is a difficult question to just answer off without seeing the patient, but what I can tell you this: if you had a vascular surgery to improve blood flow to the leg, and that surgery went well, and you now have good blood flow to the leg, you don't have any sores anymore, you don't have any pain from the lack of blood flow to your leg, and your leg is actually now getting the blood flow it needs, and that's actually when I would recommend that you get a knee replacement.
While it's at its height.
It's
So
your leg has now been improved to recover after surgery. One of the things that I typically run into with patients is actually the exact opposite. The patient comes in. We all know that people smoking here in North Carolina is pretty common. It's one of the most common reasons to have vascular issues in your leg. So I frequently get people who have knee arthritis and vascular pain, and we have to have the vascular problem addressed first, otherwise you won't heal your surgery. So if you did well with your vascular surgery, your leg is doing well, you got good blood flow, and you still have horrible arthritis, I would love to evaluate you and see if you're a candidate.
and that's the key, come in and be evaluated.
Yeah, come and be evaluated. Different doctors have different, philosophies and positions. That's why it's called practicing medicine.
Well, at Carolina Regional, one of the things that you and I have talked about in the past, you personally are very careful and work up people completely before you'll do surgery on them. Why? Tell us why.
Correct. The reason is I don't want any of my patients to have a bad outcome. This isn't for me, this is for you. This is your knee, this is your hip. I take care of the patients that when things go bad. And unfortunately, when knee replacements or hip replacements go bad, they do go bad because we're putting in stuff for you that's supposed to last your whole life, right? And if you cut off something like your hip or your knee and you put in metal and plastic, the only thing you can do is put in more metal and plastic at that point. So I really try to get you as healthy before surgery. So like if you had a vascular condition, I'd send you to the vascular surgeon to get ready for a knee replacement. And then we proceed with a knee replacement as safe as we could. The other thing that sets me a little bit apart from other surgeons is I don't believe in tourniquet use for knee replacements. So most surgeons will still use a tourniquet around the thigh to try to decrease the amount of blood loss during surgery. I don't use it because I don't think it really helps with the decreased blood loss in my hands. Additionally, it can cause thigh pain because you have something squeezing your leg like a boa constrictor the whole case. It's probably a short-lived pain versus the tourniquet one, but still, it still hurts. Additionally, it lets people get antibiotics to the knee throughout the entire surgery that they're getting dripped in. And into the person's previous question, it's actually way better for the people with vascular disorders to not have a tourniquet on because they're already having blood flow issues to the leg. So that's one of the reasons why I ditched the tourniquet and trying to push forward knee technology, knee advancements in the area.
So what type of pre-surgery checkups do you do on people?
So we're pretty thorough. I mean, we make you take your shoes off. We will feel your pulses. We look at your feet, make sure that things are getting good blood flow. From there, we check your vital signs, check your weight, check your height. We also do a very thorough blood work. So the things that we're looking for is we're looking for your overall nutrition. We're looking for your overall health. So I check your red blood cells. I check your number of white blood cells. I check your protein levels, check your kidneys. We check your liver to make sure you don't have any underlying liver things that need to be taken care of first. We check your bone health with a couple bone labs. We check your protein levels for the precursors of new red blood cells, so after surgery you can make new blood. And we check diabetes. So we go through all of that stuff before I will tell you that it's time to safely move on for a knee or hip replacement. Because again, the national benchmark for the hip and knee replacement is a complication rate between 1 or 2%, and that is my goal, is to hit a 1 or 2% complication rate.
And you're hitting that, right?
We're hitting that,
Having
yep.
very few complications.
We're hitting that, and that is the goal, to continue with that, and we're going to continue to try to improve that without trying to, not operate on anyone. So we're always trying to push people to get healthier. If we check your smoking, the primary care doctors around here love me because I have excellent smoking cessation rates. So I think some of them just send me patients to stop smoking. But we're very thorough, and the reason is we want this to go right for you. This is supposed to last 10, 20 years, right? You took the risk. I want you to like what you had done for you and kind of just carry on through.
And that's a lot of your philosophy as a physician. You are a partner with them.
Correct.
And from what you're saying, though, if they come in and there is something they need to work on, you help them work on it to get
Correct.
ready for the surgery.
Correct.
So then they can have it.
Right.
Yep.
We need to take a quick break.
All right.
Stay with us.
See you
We'll be
soon.
right back.
It was fantastic. He was different from everybody else I'd ever seen. He's compassionate. He really cares about his patients. I told him, you were my guardian angel. My experience with Nash was A+. So then the surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
If you want fine dining that goes beyond just eating, come to Lily Ann Steakhouse. It's an experience. Exceptional food prepared by our famous chef, meticulous service, and upscale ambiance. Certified Angus beef, choice and prime, seafood, pork, and chicken, all seasoned to perfection. Book your private function with us, birthday parties, or any special occasion, or even meetings for your company or civic group. Lily Ann Steakhouse, located at 139 Gateway Boulevard. Open Monday to Thursday 4 to 10, and Friday and Saturday 4 to 11.
We're back with Dr. Bernard Kemper at Carolina Regional Orthopedics. And what's the name of this street? You're off of Zebulon. What's that?
Patrick Court.
Patrick Court, okay.
Yep, on Patrick Court, kind of right behind the Wells Fargo Sonic kind of area. And
They're on the Sunset
they're on
Avenue
the
side,
Sunset.
so
We're
go
just
around.
Go on Zebulon, and we're right behind there.
And y'all got a lot of things going on there. You've
Yes, we do.
got pain management, physical therapy,
Yep.
urgent care.
Urgent care, we actually have a vascular physician that comes in from
Oh.
Cary once a week to do the vascular evaluations for us, and he's doing procedures down in Cary that aren't offered around here, which people have been very much benefiting for.
Good.
We have wound care that we're going. We actually just opened up an urgent care as well, so that way people, when they get hurt, you don't have to wait in line for the ER and get running with orthopedic surgeon or surgery PAs for a musculoskeletal injury, or like, you know, even if it's just a sprained ankle, you want to get a quick x-ray or something like that. That's what we're really good at, that kind of stuff.
And physical therapy, that's huge.
Physical therapy is huge.
And you have it all planned out before people have the surgery to
Oh,
have
yes.
excellent outcomes.
Oh yes, we partner with many of the physical therapists around here. I think the physical therapy outfit at our office is very good. One of the biggest benefits is if you went through a hip surgery with me, or a surgery with one of my partners for the hand or the shoulder, and you're doing therapy over there and something is wrong, something as simple as like a bandage is falling off, or maybe a little extra pain, then we just have someone go over and evaluate you.
To
Right.
the physical
Yeah, we
therapist
just walk
office.
over, say hi. There's little rooms back there. We take you back in there. Just give you a quick look over, make sure everything's fine. And it saves you another doctor's visit. It saves a copay, right? It saves all of that stuff. And I think patients really benefit from that kind of continuity of care just right there in the office.
And the accountability, because I've heard, the people that I've heard through the years who've had hip or knee surgery who don't have the best outcomes are people who don't cooperate with the
Yep.
physical therapy.
Yep. So I tell all my knee replacement patients, you're not going to like me for 6 weeks. The reason is after a knee replacement, the knee heals by scar tissue. So after we do the incision and we put all these metal parts and pieces in, you have got 6 weeks to make this thing bend and go straight. And if the scar tissue forms between 6 to 12 weeks and it can only bend this much or only go this straight, that's unfortunately what you have kind of forever. So what I tell my patients is during surgery, your leg will be straight and it'll bend as far as it can possibly bend. After surgery, all your muscles and stuff wake back up. So you have to retrain them to use your new knee replacement. Most of my patients do physical therapy very well. We track our pain levels on our patients very well. All of UNC does. So we get our own personal pain scores. We get the amount of opioids we prescribe. I would say most of my patients do very, very well. I also get on them right away. All my patients who are watching this are laughing because if they know if they hit it hard the first 2 weeks, downhill slide from there. But a knee replacement, unfortunately, does take some time to get over.
Well, considering the pain they go through before they have the surgery, that's a difficult but a minor investment to have an outstanding outcome.
Correct. 80% of the people that get their knee replacements think it's the best thing they've ever done. Like, no pain, improvement in function, just way better than what they had before. Unfortunately, there is 20% with a knee replacement. They're not perfect yet, but we're getting better at them. Still have some residual pain or stiffness. That's for various reasons. One of the most common reasons why your knee replacement still hurts is actually an arthritic hip. Yep, so we'll take a look at those painful knee replacements, make sure it's not something easy that was missed. And even that 20% that still have pain or stiffness with the knee replacement is still much better than what they had before, right? Unfortunately, they're not perfect. We're getting there, though. We actually have some newer technology that I'm using.
Good.
To try
Like what?
Yep. So the traditional knee replacement just had a normal piece of plastic on it that kind of had two little dishes on it for the knee to rock back and forth. In addition, the plastic was white. One of the things that we have now discovered is that the knee isn't just a simple joint like a door hinge that bends back and forth. The knee bends, spins, and rotates. So if you can look at the difference here, not only can you see the different color, I'll talk about that in a second, but when you compare the two, which you can tell me is that there is more than just a dish on this one.
Yeah, around the edges.
Yep, around the edges, and you can see this little swoop over here that this one doesn't have.
Uh-huh.
And what
Can we get a tight, let's try and get
Yep.
a tight shot of this.
So what we're doing now is we're trying to mimic how your knee looks before you get arthritis. That's one of the big things that we're pushing now is trying to get a pre-arthritic knee.
This is the good one. This is the old one.
Yeah, it's the good one, the old one. Try to get the knee to function more like a knee that actually still has those meniscus that we just talked about. Because we want the knee to bend more, be more stable, but not be so tight that you can't bend it, right? So it's definitely a balancing act. So we're trying to use, I'm using newer technology that so far has been going very well, especially with the first couple weeks of physical therapy. My patients have been doing much better the first several weeks.
Great.
The other thing is you can see that this is a yellow plastic, and while most people think that the plastic probably should be white, what the yellow is it's infused with vitamin E.
Oh,
And the vitamin E acts as an antioxidant to decrease wearing down the plastic, so hopefully the knee replacement lasts you longer. So we're really trying to pick up some better properties on the knee to not only have it function better, but last better.
if there are people watching who had the surgery 10 or 15 years ago and that they just feel like it's starting to not be what they wish it was, do you do much go back in and fix and repair?
That's a third of my practice.
Oh, okay.
Yep, we'll evaluate anybody's painful hip or knee replacement. Sometimes they have to be redone. You know, I have to find a good reason to redo a hip or knee replacement, just because if I can find a good reason, whether the part and piece is coming loose, or it's unstable, or you simply just wore the plastic out, which is probably the least common, unfortunately. If we can find a mechanical problem and we fix the mechanical problem, the odds of you having a good outcome is like 90%, like pain
Oh,
relief.
good. Yeah.
If we can't find a problem, then it's only a 25% chance of you getting better. And that's just not worth a big surgery that carries about a 10% risk for the knee, 20% risk for the hip.
One of the questions we got last time you were on, which I think is very important to people, is what type of anesthesia do they have when they have knee replacement surgery?
Yep, so I still try to do the vast majority of these under a spinal, because you wake up and you don't hurt below your belly button for a couple hours, which is wonderful. Because
And it's not general anesthesia.
not
so-
general anesthesia. You still go to sleep, right? But you don't have all that medicine blowing through your lungs like we used to do it. It's more of like the stuff that you get for like a small procedure, like a colonoscopy. So you get that type of medicine, you wake up that quick, which is nice, versus having the brain fog for a while. And then after surgery, we put a block of medicine on top of your knee to help out with pain for the next 24 to 48 hours. Which
How do you
also
do a block on top of a knee? What does that mean?
Sure. So after the surgery's over, you go back and the anesthesiologist uses an ultrasound, and they look for the nerves inside of your leg, and they numb up one of the nerves that runs right over the front side of the knee to really help with pain.
Yeah.
Again, I take my patients' pain very seriously after surgery, and our scores, you're probably not going to have a less painful knee replacement around.
How soon do you get somebody standing up?
As soon as the spinal's worn off and they have the strength to stand up, the nursing is trained to get you up and standing. Early motion, we make you move, because we know if we make you move the first 1 to 2 days after this, and we make that knee bend the first 1 to 2 days after this, you'll be thanking us in 6 weeks. You may not be liking us that day, but everything that we're doing
Yeah.
is so by the time that 6 weeks roll around, you're like, I know where I'm going, I see where I'm going, and it's a much smoother process for the patient.
I had no idea that they couldn't undo the damage if they don't get it moving right away and that
Yep.
scar tissue comes in.
Yep, so once that scar tissue comes in, it's very difficult to get rid of. You can cut the scar tissue, more scar tissue comes back.
Yeah.
You can break the scar tissue, more scar tissue comes back. You can redo the knee. That's maybe the best possible way to do it, but that's fraught with maybe a 50% success.
And who wants to have it done all over again when you
Yeah.
could have done the right thing and made it good to start
You
with?
gotta move.
We did have somebody text in and ask about crossing her legs. She works in an office and crosses her legs all the time. Are there concerns about that?
I don't think just crossing your legs is bad. However, I would recommend that you don't stay in any one position for too long, just because the knee itself will kind of start getting stuck on itself, especially if you have cartilage loss coming in. Those little potholes, they will kind of stick together. So I don't think the crossing the legs would be bad, but just make sure you're getting up and moving around. The other thing is you don't want to sit with your knees bent too long because of the risk of blood clots. So make sure you're getting up and moving around at work. That's my
Well, and when
recommendation.
people fly, I know your partner, Dr. Perlmutter, will say he takes aspirin
Yep.
starting a few days before, and he wears compression hose.
Yep. So getting up and moving around really helps the blood clot formation to really get that to go away. All those muscles just squeeze the blood vessels and try to not have a blood clot form. So I would say just make sure you're standing up and moving around, but crossing your legs is fine.
What is the difference between a total knee replacement and a partial knee replacement?
Great question. So the total knee replacement is when you go through and you replace both the tibia and the femoral surfaces. There's my partial knee replacement on both sides of the knee. The total knee replacement, this guy right here, does both sides, inside and outside, tibia and femur.
The silver part.
The silver part is the metal part.
And the off-white.
And the off-white, the off-white, correct.
What is now off-white, yeah.
Yeah, off-white.
Okay.
Whereas the partial knee replacement just replaces usually the inside of the knee, and the outside of the knee is left untouched.
Okay, which means one side, the outside of your leg knee.
So still both the thigh bone and the shin bone, the tibia and the femur, and there's a little bit of difference on these. I like to explain this as kind of higher risk, higher reward. Not the higher risk that something will necessarily go wrong with the surgery like death or complications like that. The problem with the partial knee replacement is you still have other parts of the joint that can still get arthritis. And that's the most common reason why a partial knee replacement fails. Not because the parts and pieces loosen up. The parts and pieces have about the same lifespan as does the full knee replacement. The pro to this is if you are like an active, like let's say you play tennis, right? You're still very active on the tennis court, or marathons, or light sporting non-contact activities. A partial knee replacement can give you a more normal feeling knee than a total knee replacement.
Okay.
Because the other part of the knee, you don't do it if there's no arthritis in there, so the rest of the knee should still function a little bit better.
Can you do the one with the broader rotating with the partial?
The partial plastic is pretty much the same for most of them because you have the other knee with its meniscus to still guide the knee through those range of motions. That's an excellent question.
So you have to really evaluate very carefully pros and cons when you meet with somebody to determine what's best for them.
Correct. It's a decently long meeting for the first time you come in and you see me. You'll see my PAs and stuff first, usually, unless I got an opening, which is getting more rare. But they already got you worked up, so whenever you come and see me, I have the information, and then we can start really trying to figure out what's best for you and what you're trying to get back to.
And you're doing all your surgery now at UNC Health Nash.
Correct.
And feel very good about the support staff and
Correct.
the quality measures and everything there.
Yep, and one of our summer initiatives, I might get in trouble with them for saying this, but we're going to try after the whole COVID scenario, we're trying to get back to some more outpatient surgery, so we're going to try to get some new outpatient total joints going sometime this year. That's one of our goals. Whether or not it'll happen, I hope so. I'm very much trying to, but we're trying to get the best musculoskeletal care you can get here as anywhere else in North Carolina, Virginia.
That's great to hear.
South Carolina.
And the hip surgery that you do, anterior with the small incisions, you're the only one locally who does that, right?
Yeah, I'm the one that does it often. So.
Okay. Huh. What other dummies do you have over there? The silver thing you talked about last time?
Yep, that's my standard hip replacement we have over there from last time. One thing I did forget to talk about on the knee replacement, with the newer, have you ever heard of a 3D printer?
Yeah.
You know, the little things that kids print these little, plastic doodads with, I guess, or...
Do your kids do that yet?
No, my kids don't do it, but the company I'm using does it. And one of the things that they're doing to try to make the knee replacements last longer is they're now 3D printing the backside of these knee replacements with a metal. So if you zoom in here, you can see that the metal on this is nice and smooth. And
You can 3D print metal?
Yes.
I thought it was just plastic.
Nope.
Oh.
These implant companies are now have the technology to 3D print metals.
Wow.
And what they're doing is this is not the first time we've tried to do what we call cementless knees. But what it is we now have the technology to put on the metal in a way to really make the bone grow into it and have this be essentially a part of the rest of the knee replacement.
Huh. So what makes the bone, I know I've heard from cardiologists that your heart tries so hard to live that it creates new pathways and whatnot, but that's really interesting. Does all healthy bone try to grow into things and reproduce itself?
It does. Bone is interesting in the fact that it's one of the few organs, because it is an organ, that heals without a scar. So bone will continuously grow and then actually breaks itself a little bitty all over your body, and then it regrows to make it stronger again. So we use that to try to fix these implants into place now to have it essentially become a part of you.
Is there any surgery where you would take grafted bone from somebody else?
Oh yes. That's in the more of the redo side.
Oh, okay.
Yep, we use bone graft fairly frequently.
And where do you get the bone graft?
Cadavers.
From a bone graft thing?
Yeah, cadavers. I will harvest bone graft sometimes from the actual patient and put it back in places. Common hip problem is called avascular necrosis of the hip. Common in certain populations that are actually pretty popular down here in North Carolina. And what it is, it's kind of like a heart attack to the hip bone, and the bone in the hip actually dies. And what you try to do is try to get the blood flow back to the hip again, so that way the bone can again heal itself out of a scar. If you don't get it to heal, you'll get a hip replacement at a really young age. So we try to save the hip with a small procedure.
And if you use a person's own bone, then they wouldn't need their rejection medication, but if you use a cadaver, do they or not?
That's an excellent question. So the cadaver bone is a radiated bone, so it is essentially just a scaffold for your bone cells to more easily crawl into. And make
Even
your
better,
bone.
so you don't have to take the medication.
Yeah, you don't have to take medication for it. And then sometimes we use your own bone, and then of course you don't need the rejection medicine, but we're using your own bone to also get stem cells. So one of the few places that stem cells actually works is if we're doing a bone transplant, right? So like if you had
From your marrow?
Yeah, from your bone marrow, and we try to put it into like the part of that hip that I was talking about that had that little heart attack, and try to get it to heal itself back together again.
And you do all of that stuff?
Yep, we're doing that.
Huh.
Yep, we're doing that. Just it's a quick surgery. The results on it we don't really know because we can't take people, make their bones have a heart attack, right? That would not be quite right.
Right.
But we do know that it can prolong the lifespan of someone's hip and prevent a hip replacement at an early age.
You referenced that these are supposed to last about 20 years or so. Do some of them last longer than that, or is that?
Yeah, so for the hips, 15 to 20 years, 95% of them are on the road.
Still on the road?
Still on the road, they're still going. So if you get a hip replacement whenever you're 65, there's a good chance that that hip replacement is hopefully the only hip surgery you ever had to have. Right, we're doing better with the plastic like we talked about, it's wearing down less. We're doing better with the materials that are in the hips and the knees, so hopefully they become part of you, so that way you don't have cement break, right, just after wear and tear. You've driven down the road, you've seen cracks in cement. The same thing happens with cement inside of a hip and a knee replacement. We're doing all these things to try to get this hip and knee replacement to last you as long as possible.
Do you put I had a group of ladies at my house today, and I was telling them about you, and they were all asking a bunch of questions. Do you glue or staple the skin back together when you do these surgeries?
I only staple in two circumstances. One, if we have to get out of the OR really quick, like you're getting very sick and it's just time to stop surgery.
Oh.
That's one time.
So it's based on the patient's
And
condition?
the other time is if I just don't like you.
Oh, no.
So I don't staple you. No, staples are cruel.
Huh, but the glue just is fine, and they've got really good quality glue.
Yep. So the glue is a bunch of invisible stitches underneath the skin. My PA Morgan here in town and now Vince, Morgan was going to come tonight, but she unfortunately had a family emergency. People beg for Morgan to come and do their other surgeries because of how good her incision closure looks. I mean, her incision closure and Vince's incision closure, we do like a plastic surgery style closure.
Wow.
With the glue, with the invisible thread, and the incisions typically look very pretty. If we're doing the redo side, or if you have skin that is not able to hold the glue or the thin stitches underneath, Then we use a very fine blue stitch on the outside of your knee because it doesn't react to the skin like some of the older style stitches do, and they can stand for a long, long time. I use that on the redo side.
And does it stay or absorb?
The little blue ones we take out in the office.
Okay, because I was thinking you might not want a blue stripe down your leg
No, you don't want a blue stripe down your leg.
for the rest of your life.
No.
Let's take one more break, and we'll be right back.
Wonderful.
I'm having a really good time. I
This is
hope
great.
you are. Good. Thank you.
It was fantastic. He was different from everybody else I'd ever seen. He's compassionate. He really cares about his patients. I told him, you were my guardian angel. My experience with Nash was A+. I said, any surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
If you want fine dining that goes beyond just eating, come to Lily Ann Steakhouse. It's an experience. Exceptional food prepared by our famous chef, meticulous service, and upscale ambiance. Certified Angus beef, choice and prime, seafood, pork, and chicken, all seasoned to perfection. Book your private function with us, birthday parties, or any special occasion, or even meetings for your company or civic group. Lily Ann Steakhouse, located at 139 Gateway Boulevard, open Monday to Thursday 4 to 10, and Friday and Saturday 4 to 11.
So, folks, I'm sorry you weren't able to listen in. We were talking about robotic surgery.
Yes.
The pros and cons of that.
Yes. One of the most
What do you think?
frequent questions I get is, do you use a robot?
Uh-huh.
No, I unfortunately do not use a robot. The main reason I don't use a robot is, one, I do that minimally invasive or the anterior hip approach, and the robot for that is essentially superfluous. There's been really no study that has shown a lower pain rate, lower dislocation rate, lower fracture rate. So you have a surgery now that takes longer with the robot, multiple incisions with the robot, for no benefit. So for that reason, I've not used it on the hip side. The knee side is kind of the same situation. The robot is a tool. Some people need certain tools, some people prefer certain tools. For the knee replacement, it has not decreased pain post-operatively. It has not increased range of motion. It has not decreased 1, 5, or 10-year revision rate. So for that reason, I've not used the robot. There is a part of the newer technology that I am very interested in, and that is artificial intelligence. I'm sure you've heard everything about artificial intelligence.
How can you use that in your profession?
Sure. So what other companies are looking into right now is how to take in your body's alignment, right? So we can actually take your body, your hip, your knee, and your ankle. We can then, for the knee, we can then take where your knee anatomy is, and we can then design a program that you see in front of your face to do the bone cuts and try to put the knee replacement in. That is something that I'm following. One of the companies that I'm following is advancing in that pretty rapidly. They're doing a pretty good job in the shoulder. I don't do a whole lot of shoulder replacements anymore, so I'm waiting for it to get to the knee and to the hip. I think once that comes around, where you don't have to do extra incisions, where you're getting a little bit more information just to make a decision. I mean, again, these implants, all of these, the knee implant, the tolerance is 3 degrees. You can have 3 degrees of this way and up and down to try to get it to work right. The hip replacement is probably 5 degrees and 5 millimeters. And so far, the robot has not been able to do that in my hands or reproducibly in other people's hands. So I think there's better things to come than the robot, and I'm very much fascinated by what comes next.
Oh, I think AI is going to open a lot of doors for
AI
us
is
in
going
the
to
future.
change a lot of things.
But the 3D that you talked about, metal and is this literally what material?
So this is still your standard cobalt chrome.
Cobalt chrome.
Yep. This underneath it right here is a printed titanium.
Uh-huh.
So bone likes to grow into titanium. One of the problems with knee replacements is the cobalt chrome. Cobalt chrome is not necessarily a problem. It used to be thought of an allergy type of thing. However, it's way different than the type of cheap jewelry you go buy at the mall. However, the cobalt chrome is still the hardest metal that we have that doesn't wear down whenever it's rocking back and forth on the plastic.
Okay.
Because some of the metals we have tried before, we've tried all titanium knees and they've failed. Either the shin bone part breaks, the tibia part breaks, or it deforms the metal on top of the femur. And for those reasons, we're still back at cobalt chrome. Some of the other, there's some other types of metal. Some have the nickel-free type of knee replacements. Those have their pros and cons. There's less nickel in it. The nickel is not really measurable after the first couple of years for either knee replacement, to be honest with you, unless there is a problem where you have the metal rubbing on the metal. Once you have the metal rubbing on the metal, that switches things around because now you've turned your battery into a battery. And that will give you, for sure, metal problems.
We have a question.
Oh,
Okay.
wonderful.
Question.
Is it wise to get both knees done at one time, and do you do that?
So I do not advise knees done at the same time unless you have a certain couple of reasons to get it done. One, your knees are so crooked that I have to do both knees at the same time, because if I make one leg straight and the other knee's crooked, the crooked knee will actually hurt the straight knee.
Interesting.
that's
I've never
one of-
heard that as a reason for
One of the
yeah.
reasons why I will sometimes be talked into.
What do you
maybe-
mean by crooked?
I mean, if you see someone walking down the road and their knees are knocking together, they're bow-legged.
Okay,
I
okay.
got to make your legs straight.
It wasn't made crooked by virtue of needing the knee replacement. They were born that way.
Well, they were born a little bit that way, and as the arthritis came in, they wore it out more and more and more and more. So they either got more bow-legged or more knock-kneed. So that's one reason. The other reason that I'm very sympathetic to is if you have a job and you can only miss so much time a year and you need to get both your knees done. That is a reason to maybe have that conversation. The both knees at the same time is a very painful surgery because you don't have a good leg to stand on. So that's why I do not recommend it for most of my patients. You do need one good leg to stand on to keep getting around on. Additionally, for the knee replacement double surgery, there is a higher risk of those fatal blood clots.
Oh.
Yeah. So
What do you do to help prevent that?
So-
Blood thinners?
blood thinners. The role of blood thinners has changed a lot over the last 10 years. We used to be very, very, very aggressive with the type of blood thinner we used after hip and knee replacement surgery. We've backed that off a lot more to a simple baby aspirin twice a day for the vast majority of patients. That is as safe as anything else that we've done before. The warfarins, the Xareltos, the Eliquis, as preventing the fatal blood clots. Additionally, aspirin, in my opinion, this is debatable, definitely decreases, in my opinion, decreases wound complications because you're not
good.
bleeding after your surgery. I also think that the aspirin helps with pain control after surgery, not just because
Even the little baby ones?
even little baby ones, for the reason, not necessarily that you're taking the baby aspirin to help out with pain like you would a full strength aspirin, but you're not bleeding as much around your incision. You're less bruised up after surgery.
One of the many things I like about this show is there are people in the safety of their own home who have been thinking about things and they are able to just listen without having to make a move. But let's say somebody's sitting there thinking, I just hurt all the time. My knees are so uncomfortable when and this is not personally yet, thank goodness, but
Thank goodness.
what would you say to them as far as it's time, when will they know it's time to do something about it?
So most patients will just know when to throw in the towel naturally. When you come to my office, I'm not going to try to sell you a knee replacement or a hip replacement. I lead you down the risk benefits. I tell you, I think it could benefit you, and when you know you're going to be ready. But to your point, a very important thing I tell everybody is for knees, I tell you two things. One, once that knee starts getting stiff, it's only going to get more stiff on you. For the knee replacement, we only change the cartilage, right? We only cut off the old, frayed, worn out cartilage and replace with metal and plastic.
And so it stiffens up, then down the road you're not able to undo that stiffness
Yep,
if you let it sit for a while?
It's very difficult to undo that stiffness because all the muscles, ligaments, and tendons We keep all of that for the knee to try to function normally again. So you remember when you used to go to high school, or maybe did you do yoga or anything like that still? No.
Cheerleading.
Cheerleading, yep. So you remember how you always used to have to try to touch your toes and stretch your
Yeah.
hamstrings out?
Uh-huh.
So imagine doing that.
I
Now
can
you-
still do that.
Good for you.
Thank you.
Keep doing that. If you try to
That's-
bend down,
Keep doing that.
you
That's
gotta keep, those hamstrings are very hard to get back to make them go straight again, especially if they haven't gone straight for years.
Uh-huh.
So once your knee really starts getting stiff, there's a sweet spot to get the knee replacement done. And don't wait until it gets too stiff, because you're going to not necessarily ruin the results, but you're not going to get the full benefit.
That's really good
So-
information, folks.
So if I've been seeing you for a while, we always, I make you kick me and make your leg go straight and back. And what I'm looking for is, we give people shots for years, right? As soon as someone's knee starts getting stiff on them, I say, okay, well, you don't have to have a knee replacement. I'm not telling you have to have it. But you're to the point now where you're getting some stiffness in. Once you get stiff before surgery, you are more stiff after surgery. So if you want the best bang for your buck, best to do it right whenever you start getting a little bit
And
stiff.
physical therapy is not going to undo that stiffness.
No, because it's a mechanical problem,
Okay.
right? You've lost the cartilage, your knee's sticking together.
Anything else that you can advise that now's the time to pull the trigger?
Now's the time to pull the trigger. Is also whenever you just hurt so bad.
Hurt,
It's just
yeah.
time. You can't shake it, and you're starting to lose your daily activities. We know that if you stop doing something for a year, the chance of you getting back to it is about 10%.
Only 10%?
Yep. So if you, let's say this year, today, I start using a cane, right, for my knee arthritis. If I wait until next fall, not this fall, but the fall of Christmas 2026 to get my knee replacement done, to get rid of the cane, pretty much a 0% chance you're going to get rid of the cane. Same thing like if you used to play tennis or if you used to golf. Like I'm not golfing this year because my knee hurts so bad. And if you want to keep golfing, that should be a light bulb in your head that's like, okay, if I want to golf next year, maybe this year I do need to take a break for some other reasons, it's time to go talk to somebody. You don't want to wait too long, because it's not just the knee, it's your balance, it's your coordination, it's your muscle strength. Once you start losing that for other reasons, a knee or a hip arthritis reason, it continues to deteriorate on you, and the knee replacement won't get all that back.
What is the best preparation? Like if I come in and you say, yeah, you got to go for it, what can I do to maximize having a good outcome ahead of time?
Sure. So we are very, very, very thorough on your post-operative plan. We have multiple visits. Your visit with me, I go over your hospital stay, I go over what I expect of you with therapy, I go over what's going to happen in the OR, so that way you know coming out.
I want to interrupt you here just a
Yes.
second. I like a medical advocate too. I like if somebody comes in and they need that. Do you find it works better if they bring a family member with them to have another set of ears?
That's exactly what I was going to say. We then have 2 more visits.
Okay.
You have a visit with the hospital, UNC Nash, with the anesthesia crew and their physical therapy crew, which, full disclosure, is different than my physical therapy crew. And we go over, again, what we expect of you day of surgery, what we expect of you after surgery, and what we expect of you whenever you go home. We then see Morgan before surgery, and she goes through the exact same thing again for you.
I can't wait to meet Morgan. She
Yep,
sounds
she's
great.
wonderful. And now we're getting Vince worked into the same equation. Vince does more ankles. I'm going to try to get him on here for ankles for you. But we make sure that you bring someone with you, because the best thing that you can have is a person to help take care of you. One of the most common questions that I get is, can I go to a nursing home after a knee replacement? We very much try not to do the nursing home thing anymore. The knee replacement recovery now is so much quicker, so much faster, and we're so much more aggressive with it that going to the nursing home does you actually harm. Because we actually want you to get up, we want you to get moving, versus you go to a nursing home, people help you, right? They help you through it, so you're not getting up.
Or you can talk them into letting you slide or
Letting
something.
you slide, or you're not walking to make your sandwich for lunch. Someone's bringing your sandwich for lunch. All that simple stuff really matters. The other thing you really need to do after your knee surgery, we've talked about physical therapy. It is imperative you do your physical therapy. I can give you, or any surgeon give you the best knee replacement in the world. If you don't do your physical therapy, it won't work.
And I like that in 6 weeks, it's just basically the hardest part's over
the
with.
hardest part's over.
But even 2 weeks, you've made a big dent in it.
That 2 weeks, people start kind of becoming my friend again. Some people take the full 6 weeks to become my friend again. The maximum benefit for a knee replacement does take 1 full year.
If somebody called, excuse me.
That doesn't mean to get where you're starting at in a year. That means to get the full benefit of where we're going. And some people do, unfortunately, take a little bit longer. Everyone's surgery is a little different.
Do you have people on whom you've done this surgery who have agreed that or I don't even know if this conversation would come up, to be witnesses if somebody wants to talk to somebody who's had one, or do most people already know people who've had them?
If you meet, people love talking about their knee replacements.
Yeah.
Yeah, so there's plenty of patients of mine that would want to do something, and the ones that want to talk the most actually are not necessarily the knee replacement patients, because everyone talks about their knee replacements, but the bilateral hip replacement patients that we're doing are really want to be advocates for doing this at the same
And how
time.
many years have you been, and they're the ones where from the front and just
front hip replacement, both at the same time, versus the knee replacement question. Just hurts way less than the knees.
And the stability, that if you do both of them, I mean, that just has so many positives. And the physical therapy is the same length of time, but you knock out both of them
Same length of time.
at once.
Yep.
What are you going to talk about next time you come? You going to bring Morgan next time?
I'm going to try to
or
bring
Vince?
Morgan or Vince. I think Vince wants to talk about some ankle stuff that he's doing. He used to work with an ankle specialist.
Okay.
There is a ankle specialist in North Carolina, hard to find. I mean, there's a group in town, I think they do a fantastic job. But as far as like orthopedic ankle specialty, like ankle replacements and stuff like that, we're not doing it yet. That's something that he used to do.
He did do it. Oh,
yeah,
good. Okay.
Like some of the more specialty ankle procedures that he used to do. So he likes ankles.
And so if people want to follow up, call, is the number there, 252-443-0400.
0400.
Okay, and they can, you're very busy, but you'll get them in, or they'll see your PA and then funnel to you and
Yep,
take care of them.
We try to keep our wait time down, so that way whenever you call us, we try to keep the time for you to get into our office to get an appointment with at least someone. We try to keep that quite minimal.
Good. Well, thank you, and thanks for
You're
coming
welcome.
and sharing this wonderful knowledge with us.
Easy.
Good.
Anytime.
And thank you for joining us, and we'll see you in a couple of weeks.